zirconia is not turning out to be the product that we wanted it to be. It does break, and unfortunately, even 3Y, it's not self-healing. Why do we still call it the gold standard? Because it works. Longevity is there. Well, Mrs. Smith, what is your desire? Longevity or pretty? The beauty is that when they looked at the occlusal margins, the ones they could finish, the acceptability was about...
In this world of lithium disilicate and zirconia, is there a place for gold? Many years ago, it was agreed that nothing beats gold. Gold is the best because it gives you absolutely brilliant longevity. It's kind to opposing tooth structure, and you can burnish the margins. What does that actually mean? Right? We're actually going to cover it in this episode. What does it mean? Is there a place for gold in 2025 and beyond? I'll tell you, the last time I did a gold restoration about 3 years ago, I had to sell my left kidney to pay the technician. Gold is expensive. Are the benefits of gold worth that expense? Or perhaps, just perhaps, there's a viable alternative to gold? Well, you'll find out today. Hello, Protrusive, I'm Jazz Galati, and welcome back to your favorite dental podcast. This is a slightly different one. We did this live. This was a rare live podcast with one of my heroes and mentors, Dr. Lane Ochi, one of the geekiest and kindest dentists I know. And to see him communicate with us on Protrusive Guidance, our network, and every time we all get stuck and we're like, what do we do with this query? Or something like really obscure and geeky about material science or how things were done back in the day, then we'd always tag Lane. Dr. Ochi, is an absolute pleasure to have you as part of our community, and thanks for doing this live with us. So for those who are now listening on Spotify, Apple, or watching on YouTube, just bear in mind that I do lots of shout outs. When I do a live on Protrusive Guidance, it's very much responding to the chat, engaging, serving. So you're going to hear lots of names being shouted out. Now, every Protrusive episode, we give you a Protrusive Dental Pearl. This one is already spilling the beans. It's giving the secret away of this podcast. It's going to blow your mind, right? Many years ago, this is probably the first meeting I ever went to. It was like maybe 13 years ago. It was the British Society of Restorative Dentistry meeting. Maybe I've told this story before to you guys. I've been speaking to you guys for 6 years now. I can't even keep track anymore of what I've told you and what I haven't told you. Anyway, back then we are moaning about the price of gold. Now I had a check, and actually since that meeting, the price of gold has doubled. So here we are in 2013 moaning about how expensive gold is, and now the price has doubled 12 years later. So we asked a restorative specialist, what should we be using? And so what this specialist said back then, which always stuck with me, is to consider the use of a milled cobalt chrome. That's right, a milled cobalt chrome for your indirect restorations such as crowns and onlays. So since then, when I've got second molars and I'm tight for space, I've been doing non-precious metal crowns and onlays. And I've been pretty happy with how they fit, and especially with how much they cost. And did you know that something like cobalt chrome is so kind to enamel, right? So any opposing enamel, it is so kind to it. But is this like a forbidden cheat code? And there's a good reason why we perhaps shouldn't be using this. Well, stay tuned, my friends, because I asked this question to Dr. Lane Ochi, and let's see later in this episode what he had to say. But as far as the pearl is concerned, that specialist believed in it. I believe in it. In fact, recently, if you're on Protrusive Guidance, you would have seen me do a live. I treated a cracked tooth case, and I walked you through exactly why and how I prepared this for a cobalt chrome restoration. I show you the entire prep, the cementation, and this is available with the CPD CE quiz. We are a PACE approved education provider, as you know. So if you're curious about metal restorations for compromised second molars when you're lacking that space, check it out in the premium clinical video section of the app. And speaking of the app, I just want to do a shout out to Dr. Jamie Adamson. Jamie said on the app, thank you, Jazz, for the availability of your VertiPrep course. Fitted my first anterior VertiPrep crown today and just plonked it on. Loving the soft tissues especially. Appreciate your commitment to helping the protrusive community. Well, Jamie, to you and everyone who's started to do VertiPreps since doing VertiPreps for plonkers, thank you for implementing what you're seeing online, right? So I always worried when I created VertiPreps for plonkers because I was like, can you actually learn VertiPreps online? Do you not need a hands-on? And honestly, with the loop mounted footage that I have, or it is very possible, and we proved it, okay? Dozens of you have been posting your preps and your cases, and so we discussed the lab protocols, materials, troubleshooting, and because we have all that and the images and full protocol videos, it's as good as shadowing someone. In fact, I had a student shadow me recently, and she'd actually shadowed many dentists before. And the same thing that happened to me is that when I'm shadowing someone, I'm like over their shoulder, I'm trying to see what they're doing, I'm trying to like make notes and watch really carefully how this dentist is doing something so I can learn the nuances. But it's actually very difficult to see what the dentist is doing. So what I do when anyone shadows me is I sit them on the sofa opposite, I give them an iPad or my laptop, and I switch on my loop mounted camera, and they can see everything, and I'm speaking to them as I'm doing the procedure. And they are absolutely gobsmacked at the end. It's like, wow, what a powerful learning experience, because your vision is so clear. That's why, my friends, you can learn vertipreps online. You can learn sectioning and elevating online. You know this already because I know you go on YouTube and you type in certain procedures that you're about to do, whether it be delicate layering of anterior bonding or certain steps in dentures. The University of YouTube already exists and does a good job. I'm just here to pack a punch and contribute to this education, and the best of it happens on Protrusive Guidance. A quick shout out to 3 individuals from PG who I just want to give a lot of love for. You guys are just mentoring and helping out and contributing to such a huge scale. Mohammed Wazafari, Richard Coates. Richard also did a podcast recently about finances, like how should we budget our finances. That's a private podcast only available on the app, but you can check it out. And also Harpradeep Kaur Ratia, our friend from California. You 3 in particular have just honestly upheld the values of the nicest and geekiest dentist in the world, alongside our guest today, Dr. Lane Ochi. So thank you. And now let's get to the main interview, and I'll catch you guys in the outro. It's so great to see you again. How's life? How are you? Tell us about just a flavor of life as it is at the moment.
Life is wonderful. It's so fun to dabble in dentistry as an educator still. Don't tell anyone. I am an associate for one of my mentees, and helping them learn how to let go and bring in their own associates so they can spend more time with their family. And it also is a deep appreciation of why I really wanted to step away from full-time clinical dentistry to be a full-time grandfather. It's just this whole life balance. I'm glad I was young enough to make this decision to enjoy. So I'm probably the happiest I've ever been. So thank you for asking.
That's exactly why I asked, because I knew you were going to say that. I've been seeing these images of you and your grandkids, and you, like, honestly, your fitness levels and how much you're trying to maintain that. It's an inspiration. So I think it's a great to live up to. Like, everyone knows you here, right? You've been on the podcast before. Everyone knows you. So many of us came to join you live in London when you came recently. But just for a few people, can you just give us like a 1-minute highlight of, like, imagine your career, clinical dentistry career, was made into like an Instagram reel of 60 seconds. What would be in the highlights?
Yeah, that's easy. You're looking at the ultimate beneficiary of mentorship. So, I have been so blessed that so many doors were opened. And as and the doors were opened by generous souls like you. I mean, we don't have enough anchors and mentors that invite people to come and learn. And that's basically it in a nutshell. So, God bless you. Thank you so much for everything you do.
I mean, it's a real shame, because those of you who don't know, like, you just stumbled on, you're a new grad, and you never seen Lane before. Like, if you just type in his name in Google, see his amazing plethora of educational things he's done. Like, even online bit came later in his career, but what I've seen and what I've heard, and you have actually just, even on Dental Town, the amount of forum interactions and the amount of people who you've mentored is just amazing. And that theme of mentorship will keep coming up every time we meet. And you are the original dental geek. So an absolute pleasure to have you again, Lane, your old nickname. We've got so many questions for you, right?
Sure.
Gold. All right, we're gonna talk about gold. Okay, so before you joined, I don't know if you were there for that bit. I asked everyone in the chat, how many gold restorations has everyone placed since COVID? And I said about 5. And most of the answers were 0. Miles said, yes, he has placed gold. He didn't say how many, I don't think. But the numbers are low. Okay, numbers are low. Now, this is because as a new grad, I was not really taught how to do gold. I was more PFM, and then I had to kind of learn it. And to be fair, I kind of was making up a little bit, reading Schillingbergs and trying to do my patients, like the whole thing about burnishing the gold margins. There's so much to talk about today, but the place to start is, maybe it's a terrible place to start, but is our conversation, is this podcast the last goodbye for gold? Is this like a farewell to gold? Or with this conversation, can we see a indication for gold still in 2025 and beyond?
I think that this is this is one of my favorite ways to start a lecture is if you're going to quote me, please date me. Honestly, I think we're going to see a resurgence of gold. Zirconia is not turning out to be the product that we wanted it to be. It does break. And, unfortunately, even 3Y, it's not self-healing. It just turns out that the crack propagation occurs very slowly. It is by its very nature probably going to fracture in areas where we don't have a lot of room, meaning the lower second molars, upper second molars. And as that happens, you're always going to find a subset of patients and doctors who want longevity, value longevity over aesthetics, especially second molars. And with that, I think, the beauty of gold is exactly the polar opposite of zirconia. Gold's strength is that it's weak, meaning it wears, it adapts. Our bite is constantly changing. So the most bite force, as we know, is our second molars. So I think as the profession moves on, as we mature, as our patients get educated with us, that we're going to find a place for gold again, because people just don't like replacing broken things every 5 to 10 years. They just don't. I mean, those are from dental school. I mean, talking other dental students, we didn't know S from Shinola, yet they're here 45, 46 years later.
Wow.
Oh, cemented with crap water-based zinc oxyphosphate cement.
Well, that was one of my questions. Like, okay, so you've answered it already, and I love how you really explained the properties of gold very, very simply. The whole self-healing. You use the word zirconia not being self-healing, but really we're trying to say gold has those properties. It adapts with us, and the longevity and the data supports gold long-term. And you said an interesting thing, that it was done by students, so inexperienced operators with cements which are not as good as the cements we have today, yet in your mouth, they're still there, still functioning well. And in your career, as you were doing, like, did you find you had a phase where you tried some new ceramics and then they failed, and then you tried other materials and you will find that they failed, but perhaps you were just seeing gold just standing the test of time? Is that what kind of recollections do you have in terms of longevity of materials?
So you know how long disilicates have been around? Can I ask? Do you know when they were introduced?
Does anyone know in the chat? When disilicates were introduced? Because my guess where they were popularized was like early 2000s, but you're probably going to tell me they've been way before that.
1980, Dicor. Dicor was the first disilicates. And I have a Dicor machine in my garage. I was one of the first people to purchase it based on the recommendations of the ceramic expert at the time, Ken Malamet. And they all failed miserably within like 3 years. So I kept the machine to remind me that, we have to be careful not to be beta testers. There's a reason legacy concepts are called legacy concepts, because they've stood the test of time. I mean, how long has gold been used in our profession? I mean, generations. And it still has, why do we still call it the gold standard? Because it works. Longevity is there. That's why, if we ask ourselves, more modern materials, right? Why do we make a distinction between bonding and plonking on things with cement? So my learning curve was with all ceramics, I bond bicuspids forward, I plonk and cement molars. And I base my material selection based on how I want to do things. So gold's no different.
Nowadays, I see those who are using gold. I remember attending a Jason Smithson lecture, and he was treating a student, a dentist student. And the student said, or young dentist said, "Hey, this gold you're about to do for me, can you bond it?" So that scenario of the lower second molar, where I will go for metal, for cost reasons, I had been shying away from gold, and we'll come to that. Okay, we'll come to that, and alternatives in cobalt, chrome, and that kind of stuff, which I have been using rightly or wrongly, and I'll get your advice on that. But when we have an option, like we've got a gold, we can either cement it or we can bond it. Is there any advantages? Because now young dentists are comfortable with bonding. We're doing our lithium disilicate, we're enjoying our rubber dam. In those scenarios, could the bonding give us additional benefits?
It can. Again, if I reflect on my first use of the word legacy, I mean, because we use such crummy cement, zinc oxyphosphate is 10 times weaker under compression and shear than our resin-based cements today. So our cements are far superior. And the thing is that our preparations for gold were designed with intent to have resistance features, right? So, you try on a lot of these indirect restorations in gold. Sometimes you couldn't even take them off without cement. So we've probably modified our preps a little bit. I know I've modified my bonded preparations to take advantage of some of these resistance features. Like I do like potholes and isthmuses, and I think we've had a conversation about that in the past. But yeah, MDP is a very interesting product. It will bond to metals. And so I would not discount resistance and retention features, but yeah, we can bond gold. And, Panavia is a wonderful cement. It gives us enough working time, because I heard you while you were trying to get me up and live talk about asking about burnishing. I mean, that was the beauty of zinc oxyphosphate cement. We could manage the setting time by what we call delayed mixing and using a cold cement slab. So we had plenty of time to work with our margins. Well, resin glass ionomers, Panavia, all give us the same amount of working time. So we have much better products that can be utilized in the way that you mentioned. So yeah, we can bond metal. Absolutely.
I mean, I think you're saying for me, what I was expecting to hear is that the word space, when you're tight in space, when you're cramped for space, those small clinical crowns, that's exactly when I've been turning to good old metal. Again, not gold for cost reasons. We'll come to that. But I find sometimes if I can't put my slots and grooves in, or if I just have a doubt that, okay, perhaps I wasn't able to deliver as much retention and resistance form, option to bond is quite attractive, using MDP, using Panavia. So I'm glad you're not against it for any reason. I don't know. I worry about it going against the initial intentions of how gold was classically used. And I was thinking, is this like a forbidden cheat code that we shouldn't be using?
Not at all. So again, every question in our discussion begets another observation. The reason that we can't get away with subtractive milled restorations on short preps is that we can't mill it fine enough to get in there. The simplest thing, and one of the beauties of our modern cements, are their film thickness is so thin, because the thicker the film, once our cement film thickness goes past about 50 microns, right, the retention of a crown, the shear force strength, the shear strength of the cement drops off the table. So, subtractive milling, unfortunately, won't get into all that fine detail on grooves and boxes and potholes. So again, this is where lost wax or milling differently. This is kind of an interesting thought, and I didn't think I'd mention this, but we know from studies, and a very good one was done by Russell, one of my residents at the San Antonio Grad Pros program, looked at cast gold restorations and milled gold restorations for marginal fit. And it turned out that untouched, the milled gold restorations fit better than the wax invested in cast gold restorations. But when you cleaned up the inside of a cast restoration, it fit better than a milled one. But the milled were pretty darn close internally as well as marginally. And so one of the cost savings we can look at is not only using lower percentage gold, right, or even non-precious based metals, that they can be milled and the cost goes down because there's less labor, there's no loss of material. Technology and legacy are slowly coming together. They really are.
Well said. And so this brings us very nicely to, I did a live webinar recently where I just talked about how I treated this particular scenario of a second molar, small clinical crown that was cracked. And as I have been opting for a base metal, I've been opting for a cobalt chrome milled, and I was told by a mentor many years ago that this is what he believes in, because the price of gold is getting extortionate and he's been getting good results. And we know that cobalt chrome is kind to opposing metal. And feel free to Lane to give me a slap on the wrist, and tell me that, Jazz, perhaps you shouldn't be doing this for whatever reason. I'm happy to change my ways, especially if you tell me to. What do you think? Because when I last did a gold restoration, my lab bill was approximately £400, and so that's a lot. And it's probably double that now, based on gold, based on the pure gold weight, right? So that's a lot. So these cobalt chrome onlays, which fit really well, I've been happy with them. How my lab are making it, it was about £160. Okay, so what do you think about this choice I've made. Should I stop?
No, not at all. At $3,300 an ounce, that was gold spot price this morning, US dollars. It hit 35, last week? So it is, unless your pet client, unless you are willing to charge your clients the gold difference, and they're willing to pay it, then it's really kind of off the table. Now we could drop down, and still be in the precious metal world. I mean, we can have noble metals, less gold, more platinum and more palladium, but you're still faced with the same costs. There's nothing wrong with non-precious at all. I mean, I think it's, it's great as a metal. It sucks as a metal to support ceramics. Unfortunately, with non-precious, for those of you who don't know, we have to create an oxide layer on our metal for the ceramics to bond to. And if you look at ceramic failures on PFMs and you see metal, it's typically a non-precious metal. And what happens is the oxide layer just continues to grow over time until it gets so thick that it breaks off. But as a metal itself, as for an onlay, partial veneer gold or got partial veneer crown, it is a wonderful material. The only downside to it is that we can't burnish the margins as well as you could with high noble gold. But, our ability to capture tooth detail, iOS or PVS and machine, you really don't have to touch your margins if you captured a good impression digitally or with conventional analog impression material.
That's extremely reassuring. Now, burnishing with the base metal option, the cobalt chrome that I've been using, firstly, reassuring that if we do all our impression work, scanning, and we get good quality data, we can get good margins that don't need to be touched. But with gold, the whole burnishing, firstly, what actually is it? And was it always necessary, or was it when you felt as though, I'm going to do it here because I want to improve the margin that wasn't good enough?
You really want to hear the answer to this? There are over 280 something ways that a crown won't fit. It's quite fascinating. And the burnishing came around from the concept of the mu angle, which is a bevel on a shoulder. And the logic is that as crown horizontally seated, if you had a bevel angle, it would seat faster than the horizontal component. Well, that's fine in physics, but nobody took into consideration loose cement between the tooth and the crown. So you actually ended up with a restoration, because we were prepping bevels, because that's what we were taught, depending on how old you are as a dentist. As the crown seated, it didn't really fully seat on the bevel, so you had to burnish it to make it fit. And burnishing simply is taking advantage of the physical properties of gold and manipulating it and pulling it from the gold onto the tooth, right? And so it was an ends to a means because we did not understand all the interactions and our choices. And the other problem, again, with zinc oxyphosphate cement, even the most careful mixing, its film thickness is very unpredictable. There's no measurement. It's feel. And so it's temperature. So our castings didn't always fully seat. So we needed an out. And that's where using higher percentages of gold, this is where the use of type 2, type 3 was typically used for onlays, type 2 for inlays because it's softer, so we can manipulate the gold. And it worked well. But you also had to understand what you were doing. And just like when you teach us how to finish our composites, right? We spin composite onto tooth. Well, we have to make sure we do the same thing with gold. We would take Adelok sandpaper discs, coarse, medium to fine, and we would rotate it from the gold onto the tooth. So we're pulling, burnishing, and making up for all the little errors that went along the way. Remember, I referred back to Johnson that the cast restorations required work to fit as well as a milled restoration.
I'll tell you something really embarrassing. When I was a baby dentist, I must have placed my first or second gold restoration, and like one of the few in my career, right? And I'd heard, you can burnish the margins. I had no idea what this meant, right? So I asked my nurse for a burnisher, a ball burnisher, and I just rubbed because I thought, okay, maybe this is what they mean, right? And there we are. So it didn't mean that at all. I didn't see a difference. I was like, what the hell is this? What's all this fuss about? But obviously, the actual, dragging.
Yeah, you're just dragging the gold. And you know what? This where the first marginal fit clinically acceptable margins came from. It came from Christensen, right? And if you don't remember the study, Gordon just prepped a bunch of MOD onlays on bicuspids, fabricated restorations, cemented them. He finished anything on, we'll call it the occlusal bevel. So anything near the occlusal, he finished the proximal bevels, but he didn't touch the gingival bevels and made sure his evaluators couldn't see the gingival bevels. So, the most evaluators noted that a margin at the gingival where they couldn't feel it was clinically acceptable at about, 50 microns plus or minus the standard deviation. But the beauty is that when they looked at the occlusal margins, the ones they could finish, the standard the acceptability was about 2 microns. So, wow. When you can get at it, you can finish it. It is evident. And that was, again, the beauty of gold is it adapts to occlusal changes. It's soft enough that you can pull it and adapt it, to the tooth. So, it was, again, an ends to a means. But now that we've eliminated a lot of these uncertainties, by milling, and you have to remember what we were doing back then. What were our impression materials? PVS was nowhere to be seen. Addition silicones, they're nowhere to be seen. What were we using? Hydrocolloid, polysulfide. These are terribly inaccurate materials.
Fine. So I can see the necessity and why you would do that with the better scanning and pressing techniques. I can see how that's the equation is completely different and in our favor, which is great. So bevels are out. Does that mean that if anyone's replacing preparing for their first or very few gold restorations that we get to do, that we should be opting for shoulder chamfer?
Well, for partial coverage where you're capping a cusp, you could follow what you do for ceramics. Just a longer bevel. It could just be a shoulder. It could be a butt joint. Again, because we don't need to finish. Let me back up a step further. So the best closing margin angles when there is cement luting agent present, right? Doesn't matter what the luting agent is an exit angle of either 35 to 45 degrees, which is just like a light chamfer, or 90 degrees, which would be a butt joint at the occlusal. So both of those, if you keep in mind exit angles or angle that the restoration meets the tooth, if you have one of those two criteria, 35 to 45 degree bevel, or just a butt joint, 90 degrees, those are going to seat very well.
In terms of the angle, so is the angle of the finish margin, is it regardless of the material? The ideal 30 to 40 and also the butt joint?
For my preparations actually are pretty similar, both gold and ceramic at this point. So yeah, I would say that this is going to be tough. Okay. Without pissing anyone off. Okay. I don't understand a lot of what we see in biomimetic dentistry. To me, the design of their preparations and their margins are wonderful in the compression dome concept, right? That this is going to work. Their designs, their margin exits are perfect for maximum compressive strength to the tooth. The problem is the off-axis loads, and understand all indirect restorations fail to buccal lingual off-axis loads, right? So this is where I prefer a little bit of coming over a cusp tip, a little bit of a shoulder or a chamfer versus just that kind of butt joint. So think of it in terms of resistance to coming off. We know that retention is this way, right? Path of draw. Resistance is if you put a groove in the prep or you have shoulders, right? It's preventing off-axis loads and puts your cement slightly under compression under those off-axis loads. So when it comes to capping a cusp, I think this is what the question is. Do you prefer a bevel or do I prefer a chamfer around it? it depends. Both will work. One you may pick because you don't want to drop interproximally and get longer axial walls in, say, a groove or a box, right? Versus, I'm going to keep this whole thing high water, so maybe I'll put a little pothole in and a little circumferential shoulder, get up at the occlusal, third of the tooth.
With the slots and grooves that you might place, I found in the past when I was a bit overzealous with them, and I was going for, at this stage again, non-precious metal, but I found that sometimes my seating wasn't good. There was rocking. I'd have to use occlude spray and then figure out where to adjust to get it to fully seat. It was a real ball ache. And then now when I keep it simple with just one sort of groove, things fit more predictably. They still have good retention, resistance form. Is this a scanning PVS error, manufacturer error, or compounding when it got too many intricacies?
I think it's both. We have to find that sweet spot that works, in our hands, but more importantly, works with the lab that we're using to work with. So, how many of us actually ask for the proposal of a single unit crown? Have you done that?
So a proposal, like for example, like an ExoCAD design, would that count as a proposal?
I've talked about the milling proposal, the actual milling.
No, not at all. I don't know.
You'll do that, and you'll be kind of surprised at where you need to change your preparations. We think we round over things enough. We think they're smooth enough. But then you have to remember, a milling machine can only mill to the diameter of the smallest milling burr. And so if it's too tight or a little too sharp, the only choice the milling unit can do is overmill, which typically, if it's in the wrong place, can actually lead to a little rocking on your restoration. It's not an internal high spot. It's just there's more slop. I suggest everyone do that with their laboratories. Ask for the milling proposal, and so you can see the cutaway of where it has to overmill. You'll actually be quite surprised, and based on that, you might change your preparation design to be simpler as you evolve to, Jazz.
I mean, I did that for my zirconias, and when I went to Marco's course in Sicily, and he showed us all these issues with milling and the burr and how you have to keep in certain dimensions, otherwise you have these cement gaps. And Costas has just mentioned about Sicily as well. But I didn't actually draw two and two together for gold, and it makes perfect sense if we're going for milling for gold or non-precious metal. The similar complications can arise. So that's a very good point. The next question I had was, again, a stupid one, and shows my inexperience in this, is inlays. Let's say a gold inlay, right? Would the entire restoration be gold, or would it be that you build up a very generous core and then prep back so that you're using the least amount of gold possible and therefore saving the lab fee, and therefore you don't have a heavy bit of gold?
Foundation fillings all day, every day to minimize gold content. And it's very interesting. I heard you mumbling about Richard Tucker gold foil study clubs and Tucker cast gold study clubs still exist around the world. They're not as popular as they once were, but they still do. And I used to look at Dick and go, either your patients don't brux, or you're just the luckiest guy on the face of the earth. Cause, he would always, base up an inlay, the pulpal floor, and he'd put a pothole, indirect with more retention into the foundation filling. And what's the point of that? Well, he understood buildups much better than a young Lane did. And so, you could do that. In fact, it's so funny, back in the days, I remember when I graduated from dental school. Well, let's see. I started dental school. You'll love this story. On the board, first professor, oral surgery on medical history, writes the number 35 on the board. Never mentions it again. Whole lecture goes by. And at the end of the lecture, typical professor, are there any questions? And so I goes, what's 35? Do we need to know that? Is it something important? He goes, that's the spot price of gold per ounce right now. If I were you, I would take all your student loans and buy every ounce of gold you can buy, because I guarantee you it's not going to be 35 by the time you graduate. Fast forward to the time I graduated, gold was 900.
Wait, it went from 35 to 900.
$900 an ounce. So we were still, as students, then we had to wax and cast, we had to do all our own lab work. And the school, in ways to try to save money, in the wax pattern room, we would sit there. They would make us try to use a round burr and scrape out the inside of the wax pattern to cast it to save gold.
So we need to build a foundation, build a core to save on gold. To make sense, and so that makes total sense.
But by the way, a number of older studies, they haven't been replicated in a while, so I don't really cite them very much, showed that just in vivo studies, teeth prepared where foundation fillings replaced, they could be amalgam, they could be composite, they could be whatever, tended to leak less than castings fit to a preparation without foundation fillings. So again, I think it goes back to this whole milling internal accuracy. If you have too many undulations that, your poor casting has to fit on, it's either going to hang up on a high spot, a tight spot, right? So it does make sense.
And then what about minimal thickness? We talk about ceramic all the time, minimal dimension. What about good old gold, right? We're in a tight spot, right? We're in a second molar. It's a tight spot. And we're thinking, are we going to have enough space? How much is enough? 0.5, 0.7, 1 millimeter?
God,
how much do we want in the load-bearing areas?
Right. So this is the beauty of nickel chrome. 0.5 millimeter is more than enough, right? Obviously, if you're going to use type 2 gold, 0.5 millimeter is not enough. If you're going to use type 3, depending on the parafunctional habits of the patient, you're probably okay, but they will wear through it. And so you go to type 4, which is, the hardest yellow gold we have. But yeah, with the materials you're using, and just 0.5 millimeter is fine. We could expect good.
So with the ones with the non-precious metal I'm using, 0.5 mil, which is great.
Yep.
But then when those who are using gold, you said, just remind us again for the younger colleagues, type 1 is the highest gold content, the softest, not used very much, type 1. Type 2 is more for inlays. Type 3 for gold and frameworks. Sorry, for onlays and frameworks. Is that right?
Yes.
Crowns and frameworks?
Yes. Yeah, that's a good, kind of application. And type 4 is the hardest noble gold. And so, when you don't have a lot of room, 0.5 millimeter, it would be well indicated. Mm-hmm.
Okay, that's great. And then when we are temporizing, so if it's 0.5 mil occlusal and then buccal lingual is 0.3, 0.5, whatever it might be, then if you ever try doing, as I have, a bisecral, it's going to be like onion skin thin and it's not going to work. So what techniques do we need to employ to provisionalize for gold?
Hello, YouTube Protrusive. I know you're watching on YouTube and I hope you're enjoying this episode so far. But I wanted to highlight, in case you don't know yet, we have an amazing viewing experience on protrusive.app, our website, our network, our platform. So I just want to spend a minute to show you what this looks like. On the left side, you see the navigation, and when you join the app, you get a 1-minute video tour of the entire network. Now, in terms of where the magic happens, that's in the Protrusive community, because you might come for the content, but you'll stay for the community of the nicest and geekiest dentists in the world. We have all these polls, we have a chat group, there's always active chats and dentists helping dentists. And really what I wanted to do is create a really supportive environment that's not like the environment we have on Facebook, and it's built on the values of niceness and geekiness. If you are nice and geeky, you belong here. Now, to make this a safe space, we have a manual process of approval. We actually verify that you are a dental professional before you get in here. So we have hundreds of applicants a day. So if it's been about 2 days and you haven't heard anything, either something's in your junk or you need to reach out. If you're still waiting to join your tribe, email marie@protrusive.co.uk. That's MARI@protrusive.co.uk, and she'll investigate what's happened. Now, all the videos you have on YouTube are also on here, but you actually have some extra ones for free that you don't have on YouTube. So you get some bonus content that's not on YouTube. And actually for the future, I'm not taking things out of YouTube, but some things are not appropriate for the wider public, and I want to sort of safeguard that information, which is like dentist talk, if you like. So that's why a lot of the content is only here and not on YouTube. So you're kind of missing out if you're not on here. That's why I'd love for you to join there. And if you join one of our paid plans, then what you get is access to the CE quiz like this one, and you can get CPD or CE certificates, and also you get our premium notes. So these are a great aid memoir or revision for an episode to really cement your learning. And whilst we have ads and YouTube places ads on YouTube, we don't have that on our our network. So for the paid plan, you get to see all of the premium notes without any of the ads. And of course, you get to support Team Protrusive and help us to continue what we're doing. I'm just going to gloss over the Protrusive Vault, which has all our infographics and downloadables. These are all our masterclasses at this moment in time, and we're always planning to add more. And if you look at it, there's about 1, 2, 3, it's about 7 of them. But actually, if you look at the replay section, some of the live masterclasses that I've done and some of the training that people pay for on other websites is all on there, included as part of the masterclass subscription. And if you're a student, don't fear, we have a special section for you with all the student notes, which anyone can access. So for example, here is one on exodontia. So it's all there waiting for you on Protrusive Guidance. Please head over to the website, which is protrusive.app. Make an account on your browser. This could be Safari, Chrome, however you want to do it. And once you've made your login, then you can download the iOS or Android app and then log in through there. So the reason to make the subscription primarily on the website first is that you get access to a free trial, which you don't get if you do make an account on Android, iOS. If you make it on the website, you get access to the free trial and you get our best price if you sign up through protrusive.app. So our best deals and free trials are only on protrusive.app. Of course, we always put the link below in the description. And thank you so much for enjoying our videos on YouTube. But it's now finally time to level up your experience. Back to the episode.
You know, when typically, and we're going to the short tooth, limited occlusal distance, I cement it with Duralon and water. That's just my go-to. I just accept the fact that I'd rather, okay, let me back up. So the beauty of most foundation fillings, it usually involves some immediate dentin sealing, which usually means that you have less sensitivity at delivery. So for most gold, if you have a retented enough prep and you can use something like, reinforced ZOE like B&T or IRM, you don't even have to numb a patient to deliver the restoration. When we get to the shorter teeth where we need to use Duralon and water, it'll retain the provisional quite well. Oh, and by the way, I also aerobrade lightly aerobrade the intaglio of my provisional when I'm worried about it coming off. But then you have to numb the patient to typically ultrasound off the Duralon. But, most patients would rather get numb again. I'd rather numb them, schedule an extra 15 minutes, even for mandibular block, than get that phone call at 10 o'clock in the evening or on the weekend saying my provisional came off. And by the way, we'll bring it in with you. I bid on it. So
just be confused there then. So the provisional itself is like Duralon, like actually just molded on, or is it just like it's a Duralon temp?
Yeah, Bisacryl.
With Bisacryl. Okay. But don't you find that the Bisacryl was like too thin, too weak, too see-through at those thin dimensions for gold?
I have not had a problem with that. If you're really, really that concerned, because I think there's a second question in here, is that Bisacryls by nature are very brittle. And so we worry about breaking them. But, they're only brittle when they move. And so that's why you need a pretty strong temporary luting agent, because what happens, they lift it just ever so slightly, then they bite down on it and it pops off or it cracks. So, in the workaround, I can count the times I had to do this on 1, 2, 3, maybe 4 fingers, is to use PEMA, like Snap, or a PMMA, like Jet. But again, that's so much extra work and typically not necessary. So
great. No, that's reassuring, because that's basically what we all have. So we can use it, and just to use Poly-F, Duralon, something like that makes total sense. A couple of questions from the audience, and then revert back to some of my questions I had. Is any thoughts on Henry K asked, any thoughts on gold vertipreps?
Gold vertipreps. Well, where do you think vertipreps came from? The vertical prep is nothing more than the feather margin, which was the go-to standard for gold, again, for a number of reasons. Cost, right? And, again, we didn't quite figure out how to work out all the issues of fit and finish. You'll understand that at the end of the day, you want what we feel clinically is a sealed margin. We want to look at a radiograph and hope it looks pretty. So the beauty of a vertiprep crown, be it gold or zirconia, which is radio opaque, is it always looks like it fits beautifully. And so, that's really where the whole vertiprep is just a rebirth of the feather margin. And by the way, the bat burrs are nothing more than gingival rotary curettage diamonds that were created because all we had for impression material was hydrocolloid, which has horrible tear strength. So we would trough the tissue, the gingival, away from the margins to create enough horizontal space for the hydrocolloid to capture the margin, not tear when we remove the impression material. So Vertiprep, the bat burrs, it's just one big complete circle. You know, what was old once is now new.
Yeah, I love that. I didn't know. I can visualize now how it creates a space, but some people may just put cord for longer or may use a laser. That's how you were pretty much using it to create the space.
Right. And again, we didn't have lasers. In fact, all we had was electrosurge, good old fashioned electrosurge. And man, let me tell you, patients aren't happy when they smell a barbecue and they realize it's coming out of their mouth.
I always warn my patients before I use my thermocut to on high speed, no water, and I say it's going to smell like a barbecue. And no patients have taken offense just yet. Julita asks, would you still use? I know you have good opinions on it from what I've read before. Immediate dentine sealing for gold restorations, because I know you talk about delayed dentine sealing, immediate dentine sealing. So what do you advise for gold restorations? Does the material choice have a factor to play here?
Yeah, I don't think it matters, quite honestly. Again, the nice thing about immediate dentin sealing is no post-op sensitivity, right? And probably the need, many times you don't need to anesthetize at delivery. But if you're going to hang your hat on biomimetic dentistry, and I'm going to get in a whole bunch of trouble for this, they really do hang their hat on immediate dentin sealing being superior to delayed dentin sealing. Well, I can assure you now there are 2 good systematic reviews and 1 RCT. An RCT, randomized clinical trial, right? No difference. After a few months, the immediate dentin sealing is no better than delayed dentin sealing. So I don't think there's anything wrong with it. I would do it because for patient comfort and predictability. Yeah. So absolutely go for it.
Great. Thanks so much. Harmeet, hello, Harmeet. You say the biggest headache she's had recently is Bisical temp bonding to my immediate dentine sealing. What would you place to prevent this? Glycerin. That's something. Once you've set it all up, to place a glycerin, cure through it, you lose the oil, the oxide inhibited layer, and that's all fine. Personally, I don't know about you, Lane, but I don't have this issue. I just allow the patient's saliva to do that separating medium for me. I don't tend to have that issue for many years now. But anything further you can advise on that?
No, I'm the same. I just use saliva. May I ask though, I think it's also Bisacryl specific. I know I get sent things to evaluate constantly. And I noticed a couple products. I can't mention their names because I don't remember their names. I had trouble with saliva. It would adhere to my immediate dentin sealing, but I have no trouble using Luxatemp. So I don't know what you're using, Jazz, but yes.
We're using ProTemp. It's been fine. I haven't had that issue. I've had it before years and years ago. I just make sure I don't dry the tooth. I let the saliva be there and I'm able to remove my provisional, and that's not been an issue. So maybe try that, Harmeet. If you're drying before you're placing your Bisacryl, that could be then encouraging that to happen. But of course, you can glycerin cure like many of us do. April, I'm going to come to your question again, Haya, but April asks, when you talked about Durolon plus water and not Durolon plus the sticky mixing liquid it comes with, is that what you meant?
No, good question. So basically like 1 to 1 to 1, like 1 scoop of powder, 1 drop of Durolon, the polyacrylic acid, and 1 drop of water. So you're just adding some water to the polyacrylic acid to dilute it, which also thins it. You're not going, oh yeah, it's perfectly adjusted cement. You push it down. How's that feel? I can't feel my teeth touching because it was too thick. And then you go through and adjust. And if you're half a millimeter thick, you're going to cut through it and piss yourself off. So it does help to add a drop of water to the polyacrylic acid so that it thins it. And so your provisional seats better. Yeah. Great question. I'm sorry. I was not
good question, April. Well done. Excellent. Do you still use a silicon putty index for your temporary stents?
Well, yeah, I basically use the non-hydrophilic modified PVS. I use Signet by Kettenbach. Yeah. Just, for provisionals, I just use the cheapest PVS, fastest I can find. I use a plastic triple tray because I don't care if it disturbs a little bit. So, keep your costs down on that part. You could really cheap out and just use alginate, but God forbid your patient breaks or loses a provisional, then all the money you saved, you lose in time having to freeform one. So yeah, just the TVS.
I'm the same, and I'm glad you mentioned about the plastic triple tray, because that's exactly what I do for temps. I know Richard Coates messaged me earlier today. He said he watched my cracked tooth walkthrough video, and he was like, "Oh, that's a good idea." So I probably learned it from you. So we talked about indications for gold when you're stuck for space. That small clinical crown, there's still a place for gold. Fantastic self-healing material, 0.5 millimeters, all you need really. Any more as a bonus, but don't give too much. Build a foundation so that you're not having too much of it. You explain what burnishing is and why it was historically needed, but nowadays, if we do a good job, good capture of the margin, we may not need that skill anymore. But it's a fantastic ability for gold. That we had. You talked about cement choice. We talked about bonding, Panavia. We didn't talk about it, but I guess any GIC based cement, any of these modern cements will do, considering in your mouth there's 45-year-old gold crowns that were cemented with not the best stuff, the zinc oxy, as you said. Anything lab consideration? You talked fantastically about milling, actually, and how we need to be mindful of that and the parameters. Any other lab considerations nowadays for the labs who are they've invested so much in going into zirconias and, the whole, even the model-less future that we're facing, if you like. Anything to bear in mind, either picking the right technician or anything to advise the lab? Just check that they're doing this.
Yeah, I think it's just having a conversation with them. It's what the parameters that we're now looking at labs is internal spacing. Don't give me too much. I do need enough for luting. And, this dialogue goes across the board, not only short teeth, right? Shorter teeth, we don't want as much for what I would call film thickness for cement, because that's an analog, but we don't want as much spacing as we would for a longer prep, right? Where the cement has to be pushed out through. And, again, when we talk about full coverage now on a normal tooth, this is where I love some of the things that are coming out from the VertiPrep crowd is where do they excessively dye space? They dye space on the axial walls closer to the margins, right? Because again, as the cement goes down, right, if it can't escape, it's just going to put lateral pressure. And this lateral pressure may set up what we call mist fractures in zirconia. So, the workaround that is just make sure you have more room there, because it doesn't affect the marginal fit at all. It just allows the luting agent to get out of the way. The labs don't understand our parameters. And, honestly, Jazz, we do a horrible job of collaborating with our labs. We just assume they know everything, and they don't. And they don't see delivery of things. So this is where, we need to educate them about everything from the occlusion we want, that we desire, to the internal spacing of our restorations, and how fine areas that we want milled. And I would tell you that it's hard to find labs that mill metal, and so you may not want to use your regular lab for that. You may want to go to a milling specific laboratory, because it is different. I would emphasize we could get away with zirconia because it's so soft with maybe a 3-axis milling machine. But, when it comes to metal, man, you better have a 5-axis machine, going.
I'm pretty sure the labs I use for the recent cobalt chrome stuff, I've been using Precision Dent Studio for those in the UK in Reading, as I do for so much of my work. And I think they all outsource it to like a specialized milling facility in Germany or something. That's how it usually works. Peter asked about the cost, and we said earlier that, the cost is a major factor. It's so expensive. But a great point that Lane made earlier is that, look, if your patient is really bought in and then they're happy to pay for your time plus the gold, then why not, right? For my patients, I'm like convincing them that, look, can I please choose a material that's not as pretty, but because this is the best, because of the space considerations, and they don't want to pay so much, and therefore the cobalt chrome works brilliantly for them. But if someone specifically is like, I've had great success with gold, I understand, I've been educated by my previous dentist that gold is the best, then, just make sure you don't price it so low that you're not actually making your hourly rate. You got to make it hourly rate plus the material. Right. And sometimes you got to find out, okay, what is the price of gold at the moment? Speak to your technician and quote your patient. Would you agree?
It's again, it's like a vacationing at a 5-star resort. There's going to be plus costs, right? It's just, and they're built in, but they're there. Or if you prefer, it's just a la carte pricing. I actually show the lab bill. Here's the invoice. Here's the gold. And they know beforehand they're going to pay my fee plus the gold. So they know they're shown exactly what the gold price is. Now I do hide the total fee, by the way, because sometimes there's this disconnect between, how much profit we should be making patients. I remember when I graduated from school, what was it, a multiple of 5? So you should be, making 5 to, like, whoa, today that gets a little more difficult. They just, again, patients appreciate the option. They appreciate the honesty that you're showing them, but don't take off all your clothes.
Don't cheap out. I just remember this question I had earlier that I blanked out on, but it's such a relevant question for me because I often wonder, should I intervene or not? I'm sure, guys, we all have patients who have that lower molar gold crown, which has just now got like a 2 to 3 millimeter perforation, and we can see the core material, but everything looks so nicely sealed. Should we continue to monitor it? Open it, right?
Open it.
So, okay. So perforation means, okay, we need to now intervene, right?
Yeah. Patients love exploratory surgery. Look, the integrity of the restoration has been compromised by design. Your teeth wear out, like the gold wore out. This restoration may be perfectly fine, but it could be like mold, in the walls of your house. It could be growing underneath it.
I love analogy.
Yeah, right. Because everyone hates, understands if you got mold in your house, the remediation is a big deal. So we could do a little exploratory procedure. I can make a little bit bigger hole in there and look around. And if it looks fine, I'll cut back to some thicker gold and we'll put a nice filling in it. Yeah, we can go ahead and continue monitoring it. If we find that, oh boy, the decay is working its way underneath this, then I'll stop and we'll talk about what to do next. And so,
okay, that's perfect. So the intervention is basically an investigation, and if you go in and it looks clean, just rebuild it with composite back to the same level again. And if not, then now and then you can plan the new extracoronial restoration.
Yeah. You know what? Who doesn't appreciate attempts? Right? It's just human nature. Like, I trust doctor because he just doesn't say, I need it redone. He's going to verify, right? It's the old trust but verify routine. And these little things are huge practice builders, because the next time, even if you repaired it, right, and some of you will then, in the same breath tell people, you know what, you should probably get another 3, maybe 5 years out of this before we have to replace it. It goes by like that. 3 to 5 years comes around and they wear another hole, and now you can say, well, now it's time. And they go, yep, okay, let's do it.
It's a great step. And also then you gain that extra data about what the situation is. Is the mold a situation or not? Again, I love that analogy. I hope everyone enjoyed that as much as I did. Okay, some questions now as we're wrapping up, final couple of minutes. Okay. Hello, Vasi Anna Bent. She asks, my clinic uses Temp and I always think it's too thick. Do you think I can do the same technique of adding a drop of water prior to mixing? Previously, Lane, we've used Vaseline. Is that acceptable?
Yeah. So Tempon, if you add water to Tempon, that's what causes it to set. So don't do that. Vaseline, yes, it'll thin it, but remember, Vaseline is a plasticizer, so it keeps the Tempon from getting hard. So if the prep isn't very retentive, you don't want to thin it with Vaseline because it will come off. But if it's fairly retentive, then straight Tempon is fine. The trick is to get to, dry the tooth, get it on quickly and press firmly, and then have them bite on it. And when I tell people to bite, it's like so many things, right? Taking a double bite PVS impression, the workhorse of indirect restorations. I need you to find your bite on the not numb side, or I'll do a savior behind bite. And, you're going to need to keep your teeth together for 5 minutes. And when I say together on a scale of 1 to 10, if, 1 is completely open and 10 is as hard as you can clench, I want about a 5. I just want moderate pressure. So when they're biting on their provisional, I tell them I want a 6 or 7. And they go, oh, and you can see them bite a little firmer. So
I like that visual scale, if you like. It's very, very, very good. One technique I use for sometimes if your bisicle is a bit thin, this was taught to me by Sophie Lane, who was taught by Articaine, who I'm sure you use this technique as well, is when you have a thin bisicle and you're worried about it cracking on the pressure of the cement, is to just poke a little hole in it, an escape hole. So I think that's what I was thinking, like, Vasi, if you're having like a feeling like it's thick, put a little escape hole, maybe palatally, lingually, and then that'll give it a nice escape and hopefully less likely to fracture. Anything you want to add to that, Lane?
No, venting is perfect, right? And again, a little, just a little drop of flowable composite, zip, hit it with the light, and you're fine and dandy. You don't really even need to smooth it most of the time. In fact, when it comes to really short teeth, if it's an onlay, I'll not only tack, a little bit, a drop of flowable on the margin of the buccal and lingual, I'll lock it in underneath interproximally too. So.
Okay, great. Last questions. I saw research. This is from Henry K again. I saw research suggesting that gold lasts 40 to 46 years. Would that reflect the body of the research? Hence, it would be okay to suggest that gold may be better value for money than a ceramic. I like this.
Yeah. Well, okay. So here's the problem. When you're looking at the articles, the literature, you're talking about all cohort, articles, right? So Terry Donovan, the classic one is Terry Donovan, looked at Dick Tucker's patients, thousands of gold restorations, 40, 45 years. And of course, Dick Tucker did them. So attention to detail. I mean, a crappy fitting indirect restoration is going to have crappy longevity, period. It doesn't matter if it's cemented with Panavia or zinc oxyphosphate. So the truth of the matter is a well-executed partial veneer gold crown or even a gold crown will have a much longer run clinically in the mouth than anything else that we have today, meaning all ceramics, because we just don't have the longevity studies behind them. Again, lithium disilicate in its current form is pretty damn nice, but it took Dicor, Empress 2, Aris, which lasted a year, before we got to Emax. Same material, same company. It took 4 evolutions before we got there. And so, again, we're still talking 15 years, right? We're not talking multiple generations. So there are people that are going to go for longevity versus pretty. And that's I don't want to call it a marketing pitch to utilize metal in people's mouths. It's just a reality. Well, Mrs. Smith, what is your desire? Longevity or pretty? You're, say, 45 years old. Possibly, if we make it pretty, you're going to have it redone once or twice in your lifetime. That's just the odds. You're 45 years old. If we use metal and we're conservative, this restoration can last you the rest of your life. Okay.
And patients then pour their values into it.
Right. It's the patient's why. It's not our why. We're just the providers of the how we do it. We know what we do. We fix teeth. It's how we do it is based on the patient's why. And this is why, as you talk about, Draz, understanding patients, gaining their trust. Don't be in a rush to do a bunch of dentistry when you first meet them. This is where trust and value are established. And so your words and your dialogues are actually being listened to versus just going in one ear and out the other. That's critical for all of us, no matter where you are in your career, because you always want to have the patient who is part of the decision process. You've heard my dear friend and my brother from another mother, Michael Melkers. I mean, he loves to quote Albert Schweitzer. Every patient carries within them their own best doctor. It's our job to help them find that doctor.
Lovely. And Henry, just to add, you mentioned better value for money. There was a paper I saw on the BDJ. It was maybe, 10 years ago now. I saw it come through in the post, and it was like, it had exactly that parameter, gold this many years, therefore divided by the actual cost, whatever. And then, yeah, it came out the best in that regard compared to the data that we have for ceramics. And that's exactly what Lane echoed. Julita says, thank you. She always loved gold and now she knows why. Amazing. I love that. I guess the last two questions, guys, and then we will say a good thank you to Elaine. Haya asked, in what clinical scenarios might a 3/4 or 7/8 gold crown offer a superior solution to full coverage? And what are the technical risks of these designs? I like this question.
Well, again, the whole concept of partial veneer is to save as much tooth structure as possible while protecting the cusps that are undermined that you need to restore. So properly done, there is no need to do full coverage, right? Why do you want to do full coverage? You want to cover let's go from the top down. All right, why would we pick an onlay over a direct composite restoration? Well, the cusps are unsupported. They're going to fracture. Then if there's more of the tooth broken down, say the palatal cusp of an upper molar, well, now you're going to circumscribe that, and that can be done with the 3/4 crown. 7/8 crown may be necessary because, okay, now the palatal cusp as well as the buccal cusp, distal buccal cusp of the tooth is broken, so we come around that. We still have to cover the cusps. It's just how much coverage do we need to integrate everything. There is a philosophy. This is my philosophy, so again, quote me versus date me. I would rather not for the reasons that biomimetic talks about, drop margins, past the gingival third of the tooth, not because of the moire fringes and strength. It's just, I don't like margins, in non-cleansable areas. And, that it's always still, how many patients do we see that still get, caries on the roots, the buccal roots of their molars? So, that's just me. But there's really, in terms of longevity, a well-designed 3/4, 7/8 partial veneer crown is going to last every bit as long as a full coverage. And the reason we've gone back to partial veneer coverage and why I do like biomimetic is that the more tooth we preserve means the more we have to work with down the line. There's a point where a tooth can't have any more work, and we never want to get there.
Well, whilst we argue about the merging data and how some of the data may be in vitro and we need more in vivo to be able to substantiate some of the biomimetic claims, one thing Pascal Magnier said in a recent podcast, coming out tomorrow actually, guys, on Protrusive, is he said the real crux of biomimetic dentistry is if something fails, the tooth is still there to work with, and that's got to be loved, right? So that's great. Thanks for your wonderful questions, absolutely brilliant. Last one, a crazy one. What about gold crowns on implants? I know of a madman who wants gold on implants. Are there any strong contraindications?
None whatsoever. Again, we started this whole conversation as gold's weakness is its strength, right? Implants don't have PDLs. Think about this. Some of my biggest zirconia failures were all on X's, opposing all on X zirconia. So they just broke. And we're talking well-designed connectors. These things were thick, but yet they still broke. We sent them in for fractographic analysis, and again, the failure mode was again one was a tool grinding mark that just never healed. But the sheer fact is that having a softer, forgiving, adaptable material on top of an ankylosed tooth, which an implant is, I think is a great idea. It's just getting patients to accept it. So do it.
Eliana, if you've got a madman, go with it, use it as an experience to deliver something that's going to probably stand the test of time. And, as we know, implants are ankylosed, as Lane said, so it makes a lot of sense, So amazing. We actually managed to rattle through all the questions. Lane,
nice.
What I love, I just want to show some appreciations. I love your just no BS way of just educating. Honestly, I just feel when you, as someone who's a podcaster, and I don't know, maybe I've shared this publicly or not, but of any guest I've ever had on the history of Protrusive, or maybe I ever will, you have been my favorite in the sense of easy to podcast, because I ask something and you give a wonderful, coherent answer, and then you stop and it's like, wow, okay, that was like, you just put it on a plate for us, and it's like, you're like, okay, next. And honestly, it's just brilliant. So thank you for your education style. Thank you for your wisdom. Thank you for all your contributions to our little community over this 1 year so far, as we're a baby community growing. And thanks for your, everything you do. Everyone just pouring in with the thank yous, and it's just so nice to see. So, and Peter agrees with my sentiments there. And Miles, thank you so much for joining us to make things practical, understandable, amazing. Thank you so much, Lane. Anything to add? Are you coming to? I know you hate flying. I doubt you're coming to Europe anytime soon.
No, but there's these two guys that are speaking in Chicago midwinter at the AES next year that I think I will fly to see. So.
Oh my God, that'd be amazing.
For those of you who don't know, the American Equilibration Society is one of the premier restorative academies in America. It is a huge honor to be asked to present in front of this group. Jazz and Mahmood are online to speak at our 2006 meeting. So, my hat's off to you, from mentee to mentor. This journey is wonderful. Thank you for everything you do. The torch, honestly, my friend, as a mentor and an educator, is being passed to you, and I cannot think of a better person. So, keep what keep doing what you're doing, man. I love it.
Honestly, thank you so much. I mean, me and Mahmood, we talk about this the next year, February, and we get this major imposter syndrome because there's such an amazing crowd and all these educators. And thankfully, they gave us the paracetamol slot on the second day, first thing in the morning. But it's great.
We're hungover and grumpy then.
Perfect. Honestly, it's so. I mean, what a lineup, right? We've got Jeff Rouse, Dania Tamimi, Lucas Lashman. So, guys, I would love for as many people as possible in this chat here to come and join us in Chicago next year. Hot dogs on Michael. Michael's going to buy us all hot dogs. It'd be great. Oh, Pradeep's coming to AES. Lovely, amazing. So already, what I love here is Vasi says, "I can't wait to rewatch this amazing presentation." And of course, for those in the future listening to Spotify and stuff, hope you enjoy as well. Lane, thank you so much from all of us.
Thank you. It's been a pleasure and an honor as usual. And feel free to reach out anytime. I'll leave with one of my father's favorite quotes about me. Most of you got to hear the real heart puller commentary in London, but my dad was always fond of describing me as well. He may not be able to dazzle you with his brilliance, but he'll baffle you with his bullshit.
Well, I like that very much, and it just wraps things beautifully with the none of what you say is ever bullshit, my friend.
I love it.
It's amazing. Guys, thank you so much for this rare live podcast. Lane, thanks again for making time for it, and I'll see you on the group, and see you next year in Chicago.
That's good. Bravo. Thank you.
All right, thank you so much.
Well, there we have it, guys. Thank you so much for listening all the way to the end. If you're watching on the iOS, Android app, or the web app, scroll down. 80% in the quiz if you dare, and you will get your certificate sent over to you. We are a PACE approved education provider. If you're not yet a member, head over to protrusive.co.uk/ultimate. We've recently added splint course on there as well. So if you're looking to learn occlusal appliances, you can check that all there. So if you're looking to learn occlusal appliances and management of bruxism and protecting that delicate restorative dentistry that you do, that's now part of the ultimate education plan. I also want to take another moment to thank my team, especially some new members that we have. We've got Dr. Zaira, who joined us about 3 or 4 months ago, and she's responsible for really improving our premium notes. Also, some of our infographics that we make, she's spearheading that, and honestly, we're able to add so much more value thanks to you, Zaira. Also, a shout out to Angel, who's the newest member. She's really helping a lot with getting these initial edits of the podcast before they enter an even meatier sequence, as well as a lot of the video work behind the scenes, including editing the 21-day photography challenge coming next month. And lastly, our new manager, Alex. Alex has been messaging some of you on Protrusive Guidance. Alex, you've been an absolute breath of fresh air. We are so lucky at Protrusive to have you. Thank you for looking after the Protrusive so well. And with you as part of the team, I'm just so excited on how we're going to grow our mission to make dentistry tangible. Protrusive, watch this space. Honestly, it's a very exciting time here at Protrusive, and I want to thank you all for being part of it. Thanks for listening again. I'll catch you same time, same place next week. Bye for now.